Hello, everyone, and welcome to today's TripleTree Thought Leadership session. Before we get started, I would like to go over a few items to help you get the most out of today's session. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's panelists by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will address questions throughout today's discussion. I would now like to introduce Michael Carroll.
Good morning and welcome to Market Insights Live. My name is Michael Carroll and I'm the Chief Marketing Officer at TripleTree. Today's session is focused on the acceleration of care into the home setting. A quick reminder that the views and opinions expressed in today's conversation are those of the participants and do not necessarily reflect the official policy or stance of TripleTree and its affiliates. To begin today's session, I'd like to introduce my colleague, Michael Huey. Michael, take it away.
Good morning, everyone. I'm Michael Huey, a Senior Director at TripleTree. I'd like to welcome you all to today's webinar and panel discussion on healthcare in the home. Today, we're going to speak with three terrific panelists who will share with us their perspectives on both the heightened interest in delivering more care safely and effectively in the home, as well as the ongoing challenges in doing so. Before we introduce our panelists, I want to spend a brief minute giving an overview of a few of the key topics we'll dive into today. We'll start by talking about the impact that COVID has had on post-acute care delivery in general and healthcare in the home specifically. COVID has created some significant challenges in safely and effectively delivering care in the home, but it has also galvanized many stakeholders around the important role that home-based care delivery plays in the system. From there, we'll transition to the impact that new reimbursement and coverage models have created in home health and hospice specifically, as well as some of the ways that we expect reimbursement will need to continue to evolve. We'll then spend our time on what I anticipate will be a very lively discussion around the future of the home as a clinical setting. There is significant opportunity to deliver more care and more effective care in the home, leveraging technology by forging partnerships and clinical integration with providers across the system and other innovations. But there are meaningful challenges to be addressed, and our panelists will help us frame how to think about the path forward. Before we introduce our panelists, I just wanted to remind everyone that you can submit questions via text during the session. We'll do our best to introduce questions from the audience during the discussion to keep it as lively and interactive as possible. With that introduction, I'd like to turn things over to the moderator for this discussion, my colleague, John Hill. John?
Thank you, Michael, and good morning to everyone. We're thrilled to have you to join us for this conversation, and I am excited to introduce you to the all-star group of panelists we have to talk about healthcare in the home. Let me introduce the panelists before we dig into the discussion outline that Michael just walked through. Mike McMaud is our first panelist. He is the founder and CEO of Abode Hospice and Home Health, a national provider of hospice and home health services. Mike brings over 20 years of post-acute expertise. Prior to founding Abode, Mike was the CEO of Voyager Hospice Care until its successful sale to Hardin Healthcare. Mike was also the founder of Acumed, a skilled nursing home care business, which was ultimately sold to TLC Home Health. And Mike was also the former president of the home health division of Amedisys. Welcome, Mike.
Thank you. Good morning.
Our next panelist is Steve Rogers. Steve is the CEO of Accent Care, a post-acute care company providing home health, hospice, and care management services. Steve is bringing over 30 years of healthcare experience to this discussion. Prior to joining Accent Care, Steve was the CEO of Optum Health Collaborative Care, a division of United Health Group, which owns, manages, and provides administrative and technology services to healthcare delivery systems. Welcome, Steve.
Good morning.
And finally, Ann Tumlinson. Ann is the CEO of ATI Advisory, a DC-based research and advisory services firm that works to reform health and long-term care delivery and financing for the nation's frail and vulnerable older patients. Ann also founded and runs Daughterhood, which is an online and in-person community that connects family caregivers with each other for support and information. Welcome, Ann. As Michael alluded to, it's been a very interesting year for all of us, and also for you all that operate and advise in the post-acute environment. I would say, in our view at TripleTree, is that home health and hospice providers have been very resilient. We saw a rapid return of patient volumes. Hospice volumes were relatively stable through the heart of the April-May COVID period, but it didn't come without its challenges, from making sure that patients and your clinicians alike were safe in the home, making sure you have the appropriate PPE equipment, operating in an environment where you have restricted access to the traditional referral sources where you build relationships and capture referrals. I'd love to start with Mike and Steve on perhaps just giving us an overview or a day in the life of operating in this environment through this year, some of the challenges you faced, how you responded to those, and frankly, as you look out the windshield here over the next 6 to 12 months, with COVID still lingering, what major changes do you anticipate making across your organization? Mike, if you could start, that'd be fantastic.
Sorry,
Mike, I think you're on mute there.
There we go. It was definitely a challenge, more challenging at the beginning. We saw our home health volume drop by about 50% the first couple months of COVID in terms of the skilled home healthcare side. That has actually come all the way back. We are probably 20% larger on the home care side than we were back in the first quarter. It's been very, very interesting to watch. It went from, what do we do with about a third of our employees, which we didn't lay anybody off or furlough anyone, to how can we hire more people more quickly because the volume continues to increase. So we've seen direct referrals coming out of the hospital that would previously have gone to a rehab or to a SNF. And as a result, our average length of stay is a little bit higher, and the acuity level of our patients is higher on the home care side. On the hospice side, the business stayed fairly even, down a hair early on in the pandemic. It has come back, although a number of our top referral sources, which are facilities, congregate living facilities around the country, regardless of whether it's the East Coast, Midwest, or West Coast, still are shut down effectively, not letting anybody in, not letting anybody out, and not admitting new patients. So 3 of our top 10 referral sources on the hospice side still are not referring to us just because they're not referring any patients. The hospice side is up from the first quarter. It did not suffer the big dip like everybody else did, and we are getting patients and referrals from places we never got them before. So it is challenging. Our staff has stayed safe. We have not had, by the grace of God, any outbreaks in our team. We have about 1,600 full-time employees. We have a few people that catch it every month. No bad outcomes as of date. We do see that starting to spread, but we actually can't trace it to any facility or caregivers that they work with. It's just been mainly transmitted in their family and in their homes.
How about you, Steve? How does your experience at Accent Care compare to what Mike just described?
Yeah, I believe, COVID has significantly changed, I think, our approach to business and how we think about business and kind of delivering care in the home. And, you think about it, it's not so much that we were asked to do anything differently, because I think all the things that we ended up kind of mobilizing around were all things we were supposed to do, but it was at the speed and volume with which we had to end up doing it, right? And, I think if you go back to the very beginning, nobody can really underestimate the fear factor associated with this disease too. And I actually think one of the most important and galvanizing things we did as an organization was essentially mobilize our people around a mission of what they were here for and what they were trying to do, and get them to actually face into this disease, because they didn't know if they were going to be bringing this home to their families, their loved ones, or others themselves. Nobody knew essentially exactly the transmission of the disease, et cetera, across the board. And so, a lot of our first initial kind of facing into this was actually assuring our population and our people that they could do it. And I'm lucky in here because I have some very good people that work here, and some are ex-military. And one of the three things I turned to one of my guys who actually happened to be a tank commander. He, believe it or not, my guy who runs my hospice used to run an armored division. And he says to me, and I said to him, I said, we're going into battle, Chris. And I said, what are the things that I really have to be worried about here? How do I actually do this? And he says, you know, the thing you got to do is number one, you got to make sure your people have the equipment they need. Number two, that they know how to use that equipment. And number three, that they have a faith in leadership, right? And those are the principles in which we kind of faced into this challenge. So we did things such as, you know, we made sure that our offices had all the PPE they could use, right? And we actually did what I call like a show of force to give them a confidence that they could actually, you know, that they had what they need to go take care of these patients, et cetera. So, I mean, I think, you know, from the standpoint of, you know, being able to actually mobilize your population, face into it, we did not make rash actions associated with it. And I think because of that, our dip and our kind of recovery happened much quicker than I think a lot of the rest of the industry. We only dipped 5% at the peak of COVID, and we basically have recovered over 20%. And when I mean up above that 5%, another 15% above that. And I think it's because we kept people focused on the mission of what we were trying to do. And we supported them and showed them in the right way that we could kind of face into this. And if you look at it now, it's very interesting because the disease is actually, in the number of patients in the general given service area that we end up operating, the prevalence of the disease is worse today than it was back in March and April when we were doing this. It's just that we didn't know that at that time. And I would tell you now, it's just, we're running a business in here, right? People have the PPE they need. We have the procedures and protocols down for how to actually treat this disease. We have the kind of alignment with our partnerships out there in the marketplace around how to effectively take their patients, treat their patients, and return them back into the system, et cetera, across the board. So, you know, I would say that the major thing for us as an organization wasn't all the underlying tactical things that we ended up having to do under this, but it was actually us coming together as an organization in a very different way, in a mission-focused way, to really kind of, you know, do what we were all called to do in this particular business that we decided to choose.
That's very interesting, Steve. And maybe to use your military analogy around having the right equipment and being prepared, I'm a little surprised I didn't hear you or Mike talk about the use of technology, in particular telehealth. So maybe I'll turn it over to Ann to give her perspective on, from a regulatory policy perspective, you know, where you believe telehealth in the world of home health and hospice is heading. What do we need to have that capability fully reimbursed in this new world environment? And then perhaps Mike and Steve, I'll come back to you all to talk about more of the day-to-day operations side of things, and how quickly did you adopt to use telehealth to continue to reach and care for your patients, and how do you expect to continue to use that on a go-forward basis? So, and maybe start us off from a regulatory standpoint, and how CMS is thinking about the use of technology and telehealth to continue to deliver care in the home in a safe and compliant way.
Sure. No, I'd be happy to. I do want to say just one quick thing in follow up to just before we go to telehealth. I just kind of flagging that you know, there are a handful of individual skilled nursing facility providers out there who are, you know, having a similar experience as Mike and Steve, in that they have, you know, they had a dip and then they're getting some stabilization or some uptick or getting kind of back to normal. But as an industry overall, you know, as everybody knows, I think, you know, that's no surprise that census is way down for that industry, and probably will be for quite some time. And that's, you know, that's a result of a whole bunch of different things. But I think that at the local market level, we're going to see there's just enormous amount of disruption in the discharge patterns as a result of sort of the role that the skilled nursing facilities have played in the past and cannot play kind of going forward. So, you know, we're going to continue to be in this sort of mode where the hospitalizations are going to fluctuate based on different surges in hospital capacity in different markets. And so, you know, we kind of thought we were done with that, like, you know, but we're not, and going into flu season. And so, if you don't have a lot of hospitalizations, you don't have a lot of SNF admissions. And kind of in addition to that, obviously their ability to take a COVID positive patient or a patient who hasn't tested negative twice is limited, and it depends on the state that they're in. And then there's some consumer preferences that they have to grapple with. So, the ones who are doing well are able to kind of hang in there better than others are the ones who have already built up a lot of clinical capabilities and can do things that are, they can sort of take patients that you wouldn't typically see in a SNF. So, I would just say kind of from a home health and hospice perspective that every single market is going to be experiencing, every market's different, and they're all going to be experiencing a lot of disruption. So when we look at the data, like we just got the CMS data for the second quarter of 2020, and we kind of can't wait to dig in and sort of look and see, discharges to home health, discharges to hospice, discharges to SNFs, how do those look different than they did this time last year, and how they look different in different markets, and what kind of variation are we seeing? Because I think there's a lot of opportunity for home health and hospice, I think, to kind of to see like where the leaders used to be and are no longer, and for those like these guys here who know how to do a lot of different clinical things, kind of to jump in and take charge of that patient population that maybe previously everybody was just kind of on that little rabbit wheel of sending them to this SNF or that SNF, and now it's like, oh, what do we do? This is an opportunity for home health and hospice for sure. So just to kind of pivot to telehealth, it's a little awkward to be talking about telehealth today. I would love to be talking about it in a week when I know who is in the White House, but I think either way, as this pandemic continues over into the next year, we're going to continue to see all of the flexibilities in telehealth reimbursement that we have seen up to this point. It seems like the home health and hospice providers are anxious to be paid differently for a lot of different things right now. And I would just say kind of hold your horses, like, CMS is going to take its time in understanding the implications of all of this. And from a budgetary perspective, the Medicare Part A Trust Fund is not in great shape right now. So, what getting paid more to do things differently in the home is maybe not in the cards for the near future, unless that you're under a risk-based model of some kind.
Thank you, Ann. Maybe Steve and Mike, if you want to respond to that and provide some operating perspective on that, that'd be great.
Hi, am I on? Yeah, I'd actually like to chime in on one thing and talked about, because I think it's important. It's another population that we didn't talk about, and this is the Medicaid population and the homebound caregiver population. And as in many things, and it's something that we have seen consistently, because we have one of the larger books across the country. We have it here in Texas. We were in the middle of the pandemic in New York City at the peak of it in the March, April time period. These are the populations that are hit the highest. When I look at like deaths that happened, actually the deaths that happened were in my caregiver and in my caregiving or my caregiver and my patient client population, Medicaid populations out there. And it's because of the familial situations that they have, where they're living in close proximities at home, they're transmitting the disease back and forth. And I think sometimes we don't give them enough attention as we kind of face into this. And I think one of the advantages we had as an organization is being a very clinically based organization. We were able to support them with the PPE, the equipment, the training that population needed. But I mean, from a policy standpoint, even when you looked at like the care funds and how they were distributed, the care funds to the Medicaid populations were distributed at probably 60 to 90 days later than the Medicare funds were distributed out there, right? And when you talk to a change of business, those businesses are less resilient than the Medicare, because once you create a disruption in a Medicaid population, many of those patients don't come back. They will move out of service areas, or they are, like I talked about, the ones that are hit the hardest. And I think that's just, I think it's something for us to, and yet that is a group that is the most expensive and the most vulnerable populations that I think from a policy standpoint, we need to do a much better job in kind of facing into and being able to treat. So I just wanted to kind of put that out there, because I know that's near and dear to Ann's heart and kind of, some of her focus, but it's another part of this homebound equation that we can't actually forget about.
Can I do just one more thing and about that, Mike? I promise I'll. But because one of the things I wanted to just remember to say about sort of the population living at home with lots of high needs versus those living in nursing homes. You know, the one advantage as a business that the skilled nursing facilities have that nobody else has is that Medicaid actually is, the nursing home is the only place that Medicaid pays room and board. So, and we have this huge housing crisis for older adults right now. There just are not enough affordable units for the people who need them. And so sometimes nursing homes start to look like seniors housing as opposed to what they really should be. And I do think that is something that, you know, a new administration who probably has already sort of made some commitments to looking at. But the challenge in sort of the, you know, any kind of at-home model, if you're talking about this population, is that there's so many other, we talk about social deterrence of health and all these things, but, you know, in a nursing home, there's food. You know, in a home with somebody who's a low-income senior, there's not necessarily food or food prep. And so there's a lot of advantages to that institutional setting that are still kind of baked into the system that we have not yet unwound, that we're going to need to unwind if we're really going to make a home-based setting work, particularly for these very high-risk populations.
So a little bit about our experience with telehealth. It went from doing almost no telehealth in our company, and again, having done this for 29 years, we've experimented with all the different platforms, and there's some good ones out there. But we were currently in our home health and hospice business, not doing that, you know, across about 4,500 patients. After the pandemic hit, we went from 0 to about 30% of our visits were being conducted via telehealth. That could be over Zoom, it could be over FaceTime, it could be just over the phone. And it was very fascinating to watch. Today, we are down to 10% of our visits being done via telehealth. And I think some of that is just because the patients that we see are a little sicker on average, and they want us to come in and visit. And, you know, therapists are coming back in where that wasn't happening as regularly before. But it is interesting to watch that transition. Do I think telehealth is here to stay? Absolutely. Do I think the laws will allow us to do that? Absolutely. Do I think reimbursement at some point will follow along? Absolutely. We are experimenting and actually bringing triage to telehealth and to video online to work with our patients and our nurses and our caregivers after hours nationwide. So it's made us think about things completely differently. It's allowed us to actually touch our patients more often, maybe not physically touch them, but to actually be involved with them. Which I think is all a good thing. And I do think it will affect patient care in a positive way. I think it will affect rehospitalizations in a very positive way. And we're really excited about the future. I say, again, having done this since I was 23 years old, I think the industry has changed more in the last 6 or 7 months than it has in my entire career, which is amazing to think about.
We, you know, from our standpoint, we had a baseline where we were using telehealth, and I'd say a very traditional way inside the organization. We'd already gone down the track to also look at more HIPAA compliant, asynchronous video, text communication processes too, and had been doing some piloting on that. So when COVID hit, we had a baseline, we had a pretty good baseline kind of within our business. But we quickly actually deployed over 3,000 Medtronic units out there. And part of this had to do with, once again, the infection control. So we took an approach that, especially when it came to the COVID patients, we wanted to minimize the absolute number of visits that were in the home to minimize the opportunity for infection. So we had a combination of platforms that we ended up deploying, both the Medtronic units as well as we had basically an asynchronous, and we actually sucked up all the Verizon tablets that we could find out there, as well as redeployed all our home care home base unused tablets out there to be able to put into people's homes. And through that, and I personally actually wrote letters to the three of the major CEOs of home health health plans to essentially get them to reimburse. I got one of them to actually begin to reimburse us for the use of telehealth visits into the home. We use that to accelerate everything that we were doing. So And we actually have gone out and have had an independent study done of the use of telehealth through the crisis here. So we will be publishing a study in the next 2 to 3 months around this. What we've seen in it is the patients that were on telehealth basically had a 300 basis point improvement in admissions and readmission rates in a 30-day time period. We're also assessing patient satisfaction during that time period, and we want to use that to be able to go back to the payers and have conversations with them about the appropriate use. Now, when it comes to actually reimbursement, we'd love for Medicare and others to kind of step up and kind of find new ways to incentivize us to use this technology. But we all have to recognize also that there is, because of they have passed in the final rule, the ability for us to continue to incorporate telehealth into our care planning processes, right? And by doing that, if you look at it, on the average, we have between 4 to 5 additional visits above a LUPA in any 30-day time period here. And so the ability, if I can just replace one of those visits, you know, I could probably save about $40 on that particular visit by doing that on a telehealth versus actually going in person. If I translated that across my book of business, that's probably worth $6 million a year. So I think there's plenty of incentive in the system for us to be using telehealth. We've actually gone the next mile with it. We've identified 8 sites across the country that are our telehealth end-to-end sites that we're actually piloting end-to-end telehealth solutions, including very distinct efforts in building them into the care plans, looking at after-hour call coverage, all those kind of things across the board, so that we can actually push the limits on how you can use the technology and be able to kind of learn from it, incorporate it into the broader way we do our business.
I'm so glad you said that about the cost side of things, Steve, because if I'm sitting at CMS, you know, I'm interested in giving you, the providers, flexibility to do things, to deliver within the current payment system differently, potentially to drive efficiencies and better outcomes. If you can deliver better value, that's awesome, you know, but I'm not interested in paying you to do something that, from my perspective, should be in your best interest to do in the first place. And so, you know, that's going to be the mindset of CMS. I did want to just share really quickly, we did do a study in April on telehealth specific to Medicare Advantage and how Medicare Advantage plans were using telehealth during the crisis. And there's a couple of things that just are important to point out. One is that almost a third of Medicare beneficiaries do not have internet access. So, you know, this has got to be, we've got to address, you know, internet access if we're going to really, particularly in rural areas, obviously, and in areas where the predominant population is predominantly lower income. And as much as we, you know, assume that, you know, there might be some more flexibilities within the context of Medicare Advantage, the challenge is that unless these emergency waivers, you know, unless CMS continues to allow for more flexibility inside fee for service, it's really hard to invest in some of these technologies if you're kind of like straddling 2 systems where one is potentially paid for and one isn't. And those were a couple of things that came out during our interviews.
Great. Well, it's clear that COVID is going to drive a lot of innovation in this industry going forward. Before we leave this topic, Steve, I did want to ask you as a broader question around how hospitals and health systems are thinking about, some of them own and operate their own home health and hospice lines of business. You here in Minnesota recently announced a partnership with Fairview in terms of their home health and hospice operations. I'm curious, as you think about COVID and the overall impact that we've been talking about, how does that change the views of hospitals and health systems in whether they want to own and operate their own home health and hospice units, or they prefer to partner with Acton Care or Abode or other home health and hospice organizations?
Yeah, I think, well, then I'll start maybe as part of the conversation around, or question around associated with, you know, how health systems are viewing the home vis-a-vis in this COVID world. And then we can maybe transition that over into essentially on a go forward basis, you know, how a strategic partnership with a player like us kind of works out. If you think about it, and this is probably one of the reasons we were able to recover so faster. COVID forced us all to the table. So whether it was my health system partnerships that I have out there or my physician partnerships, we all had to face into an unknown enemy and actually figure out basically how we were going to move patients through the system in an effective, safe manner and stabilize them back out in the community. So, as we hit into the COVID time period, we had the fortunate experience of being at the table with some of the top health systems in the country. We were with UCLA, UC San Diego, Baylor Scott and White, and at the table with them actually in the planning processes around how we were going to be actually taking care of their patients in the home. And I think because of that, we did not see the dip, a lot of others, and we saw a much faster recovery, because I think what happened is it's solidified, because what I've always said in this business is the way we will be successful is when we clinically integrate with our healthcare partners, because then it kind of takes all the guesswork. When you're clinically integrated into the ED for a diversion program, or clinically integrated up on the floors on the transition of a patient, those discharge planners, case managers, all the people are just going to they're going to want to work with you, because they know that they're going to get the predictable experience of getting that patient back out of the home. So it actually forced us together to address these populations, and it kind of had the effect of moving beyond the populations, the COVID populations we were taking care of, into generally taking care of their population across the board on it. So I think that's, and that kind of caused our quick rebound. And it kind of shifts over into then why partner with companies like this, and this is part of the conversation that I think we've had with Fairview, as well as numerous other systems across the country, is that essentially, hospitals have a better place to put their capital, right? That essentially hospitals are incredibly capital intensive businesses. They are very focused today on essentially continuing to kind of enhance their inpatient services and their physician services and clinic services that they have. But they're rather immature when it comes to the home. And they typically have not invested and don't know how to invest in the home. And it's because they have other priorities within their system. And so I think that's where it becomes a little bit of the best of both worlds, that in investing in and kind of bringing alongside partners like us and platforms like us, we have the ability and are making the investments in the technology, in the clinical programs and systems, and all the other services, things that we need to be doing to effectively serve their population. Now, I think with all that said, I think as an industry and a business, I am seeing now, and in fact, I have a call later this week with one of our major health systems where they're holistically assessing the home now. They're basically recognizing that I think with a combination of basically technology and convenience, I think in the system, a move to a continuous monitoring of patients, that they need to be able to meet the patient where they actually live, right, which is in the home. And so they're holistically beginning to think about home, not from a traditional home health experience, but home from like, how do I take care of them? How do I take care of the food security? How do I take care of, making sure that they have the clinical, that they have the caregiving environment, that they have everything they need, because that's where the new treatment room is going to be. The new treatment room is going to be in the home, because I think you'll see over the course of the next 10 years, these populations that are used to getting Uber delivering their food and their basically the Whole Foods delivering their food to their home, they're not going to want to go into the physical office place if they don't have to. They'd rather actually have that ported into the home. So I think we're on a decade here of coming up that I think by the time we exit this 2020 decade, you're going to see a dramatically different delivery system in the way that people kind of begin to think about care delivery in the home.
Got it. Thanks, Steve. Mike or Ann, before we transition off of this topic, any reactions to what Steve just said?
Yeah, I agree with Steve. Look, our number one referral sources and relationships that we have across the country in 12 states are with IDNs, large healthcare networks that have their own home health and hospice providers. And we do probably 2 to 4 times as much home health and hospice as their own providers do, because we do, this is all we do. And what I have experienced in my past, I worked for HCA for a number of years and worked with a number of hospitals that had their own home health and hospice providers, from Tulane healthcare system, like on, coast to coast. And what we found is, look, they know how to do hospitals really well, right? They know how to run a hospital. They know to a certain degree how to run physician practices, but they do not know how to run home health and hospice, because it's just not their core business, to everyone's point. And so when you bring a partner in like Accent Care or Abode, whether it's formal, whether it's a JV, whether you buy the whole thing, we are able to take care of the patient in their homes because that's our focus. We are getting a lot of inbounds from large healthcare systems across the country about partnerships, JVs, taking over the operations. Would we manage their operations for them? Because they've got to figure out a way to bypass some of this congregate care living that they had in the past, that they may own or may not own, or that they partnered with. But how do we get those patients in the home and keep them out of the hospital, keep them out of the emergency rooms, and take care of the patients in a much more effective and cost-effective manner? So the amount of time I'm spending on developing relationships with these networks, even further than where we are, is I've never seen it before, and I think that will continue. They know it's important. Most of them know they don't know how to do it. Most of them are losing money at it, which I think is also interesting. Steve, I'm sure you see that. These are not profit centers for them. They are more headaches than anything else. And they're trying to figure out how to make it more important and more effective in their continuum of care.
I'm just going to say one quick thing. We can move on.
Yeah, it is.
I mean, the real value in what we're talking about right now, I mean, there's value in post-acute care where people go home and we can get them home, take care of them at home and keep them from going back. But the real value is preventing them from ever going to the hospital in the first place. And there is a limit to how excited hospitals and health systems are going to be about that. You know, so at some point, we're going to hit the limit of how much money we can take out of the hospitals and health systems. And then we're going to have to look at other kinds of payment models, you know, whether it's through Medicare Advantage or whether it's through, you know, physician-led risk-based models or whatever, you know, right. We can, you know, at some point, that's a challenging needle to thread.
Yeah. Well, let's use that point as a transition to our second topic here. And you referenced payment models. Not only was COVID a situation that the post-acute environment had to deal with and continues to deal with this year, but also some fairly fundamental changes to the reimbursement methodology with the transition to PDGM on January 1st of this year on the skilled home health side of things, but also on the horizon on hospice is the demonstration projects for the carve-in of the hospice benefit into the Medicare Advantage benefit as well. So a lot going on with regards to home health and hospice providers having to bob and weave and respond to the COVID situation, all while really changing their business model and educating their clinicians on the transition to new reimbursement methodologies, particularly PDGM. So maybe, Ann, let's start with you here and just talk about your views on the objectives of PDGM. You know, we're almost through a full year of that reimbursement methodology being in place. Do you believe that PDGM is accomplishing what it set out to do? And what are you hearing from the front lines with regards to, you know, how it's been the ease or the difficulty of transitioning to this model?
Well, I probably will defer to Steve and Mike to talk about that in any detail, but just kind of speaking from a larger system perspective, it is absolutely accomplishing what they set out to accomplish. I mean, it's the intention is, and it's a little early to say because I think we need to look at some of the claims data coming in from, you know, this full year to see sort of what we think is really going on with case mix, whether or not it's gone up, whether or not it's coding, things like that. But I think, you know, it's sort of kind of I wish we'd had, you know, if I were in charge of the universe, I would have had one more year of PDPM and PDGM before COVID. I just think it would have been really nice to have had a year because you know, just in essence, the goal obviously is to help improve the clinical capabilities of these two sites of care and to give them the incentive and the financial reward for doing so. And it would have been nice to have a year. So I think that's gotten all mixed up in COVID. I think it's a little bit of a challenge. But I think it's accomplishing what it's supposed to accomplish. I just on that point about hospice and VBID for just a quick second though, I think I was personally very disappointed at the number of plans. We have 53 plans that chose to participate in VBID. That is tiny. And unless CMS opens it back up again, you know, this was meant to be like, you apply, you get in 4 years, we're going to watch these plans. Only 53 plans came in. You know, I think CMS was trying so hard to keep it neutral and agnostic for the providers, making the plans take, you know, a few years before they could do any kind of value-based or rate pay. You know, everything is like fee for service for a couple of years, that it wasn't worth it to them to jump into this. So, you know, I don't think, you know, there's a lot of like hand wringing in the industry about this for years, and then boom, it happens at 53 plans for the next 4 years. So I would say, just don't worry about this. But think about how palliative care, what kinds of palliative care opportunities there are for you in the plan space, because I think that's where the kind of fun stuff potentially is going to happen. And we saw in the new supplemental benefits for Medicare Advantage a lot for this coming year, a lot of growth in the palliative care space. So that's, you know, that's kind of an opportunity and not a threat like we thought it was going to be.
And Ann, maybe a quick follow-up question there. Do you think the limited participation from the plans and the demonstration project is somewhat related to COVID and just the chaos and the complexity that is created for healthcare organizations to get prepared and prepare their bids for that demonstration project, or do you think it's something else?
No, I don't think so. I just think, you know, plans can only do so many different things at one time. And it just, in general, they're running this really competitive business. We're up to about 42%, 40 to 42% maybe into next year of enrollment in Medicare Advantage. And the markets are really competitive. And there's a lot going on. These are big bureaucratic organizations. And so, you know, I know an actuary that worked with, you know, a really large plan, and he was like, look how great this could be. And they're like, yeah, we're kind of busy. So, you know, bid is this little sideshow. It's not the main deal. I don't know, Steve, I'd be interested in your thoughts on that. You might disagree with me.
You know, I'll start with the PDGM, and then I'll let Mike kind of take the hospice carve-in, and then I have some thoughts I want to share on hospice though after that. You know, so PDGM, you know, if you think about like this year, it was a combination of, you know, we have COVID hitting, we have PDGM, and we're a very large player in Texas, and then we had RCD too. We had RCD hitting on March 1st, right? So the whole combination, you know, you have to say that at least when it's all coming at you, you know, you're either going to make it or you're not, right? And I think, you know, if you thought about it, you know, on PDGM, we started planning that a year out. So there was, you know, to what Ann talked about, they talked about it for years. The industry was wringing their hands for years around us. I mean, I think our biggest fear that we all forget about is we weren't sure our intermediaries were going to be able to even pay it, right? I mean, I think one of our concerns was, are we going to get the checks when we submit the bill? But, you know, from our own standpoint, we were very focused on, seems like ancient history now, things like questionable encounters, right? And getting those, you know, the whole shift out of questionable encounters and kind of minimizing those. I think, you know, one of the things you really needed to get focused on in this, and it's made us a better organization around it, is getting much more focused on getting those OASIS locked and getting those care plans done, because you've got to get those done because you only have 30 days now and you don't want to loop out, right? So you got to make sure then that you're tracking all those visits and you get to the end of the 30 days and you're not hitting a couple missed visits on you and kind of loop out on that, right? And so there was a whole focus around improving your processes and your cycle times around, you know, around the business across the board. Obviously, a big thing in this was therapy. So we started recontracting all our external therapy in the middle of the previous year, and systematically started going down that. We went to every location across the country and set a benchmark for where pricing needed to be. And then we actually, in the middle of COVID, in the April time period, completely shifted all our therapists to per visit, and kind of made that change all in one swoop. And I will have to tell you, the combination of all the planning together ended up to be that we ended up on the right side of PDGM. So once again, I think from a utilization standpoint, a financial standpoint, we've been able to effectively manage through this. And in fact, our underlying margins at a case level are higher than they've ever been associated with this. And so And I know that's not the case with a lot of our publicly reported competitors out there who struggle a little bit more with it.
Got it. Mike, how about you, both on the home health side of things, but also thinking about the carve-in on hospice?
Yeah, because we have home care, home base, and SHP, and all the things that Steve has at his company, we as well started about a year in advance as we expected what was coming. When we looked at our utilization patterns, it was going to have a very small effect on how we delivered care. Obviously, we had to make some changes. We thought that the effect would be about 0, and like Steve, we're actually doing a little bit better. And we've seen our outcomes continue to actually improve throughout it. So we think PDGM has been a net positive for our company, and I think it will ultimately be a net positive for the industry. I really do. On the carve-in, look, I've been asked these questions for 15 years now. When is it coming? How's it going to work? Is it a positive, negative? I'm looking forward to Ann and Steve's view on this. I've always had the view, and I think I have it more now. Look, I think that Medicare Advantage providers are very afraid of looking like they're taking things away from people, right? Especially at death. And if they do anything to decrease utilization or to be seen as trying to hasten the death process, I think it's going to be very bad for them. So they're very sensitive to that. I think Medicare Advantage net will be a positive once it comes. I think more people will take hospice. I think the benefit will probably expand a little bit. I think that they will pay hospice companies, at least initially, well, because they want us to take care of the patients. They know it is the lowest cost setting with the highest customer satisfaction in healthcare, and the ability for them to be seen as the good guy as opposed to the bad guy. I think it's all win for them if they do it right. And I do suspect that some of the Uniteds of the world are going to do a really nice job as this starts to come over in the next 5 to 10 years. I do think you will see higher utilization in hospice. I think you will see hospice services being provided in a better way. And I think it will make hospice companies provide care in a much better way, in a more innovative ways. Steve, what do you think?
Yeah, I think, when it comes to this benefit, to what Mike was talking about, let's start at the top level on this. We as Americans have a really hard time and difficulty with death and dying. The one thing that's helped them address that is hospice. And Americans love the hospice benefit, right? It's one of those things that has a lot of local community and provider support. And when you look at a business that is mission driven, the nurses and caregivers in hospice are some of the most mission driven caregivers kind of in the healthcare environment, right? And so you contrast that, having worked myself in managed care for a number of years, with how Americans view managed care, right? So they don't have the same level of support as your local hospice provider. That underneath the concepts of discounts, utilization management, prior authorization, or aligned incentives, these are something that Americans and people don't want in death and dying, right? It's not something that's going to resonate with them. I've sat at a table with a major health plan CEO who basically told me that as a public company, he's not interested in that business because he doesn't think his shareholders and others and the risk associated with that business is something that he wants to take on. Now, that's not Humana, obviously, right? And the way that they kind of faced into it. I think with all that said, I think we do have an obligation to break down the walls between essentially what I'd look at as a living curative benefit and end of life benefit, right? Because the benefits right now, how somebody decides to how somebody moves through the last year to 2 years of their lives needs to be done in a much more fluid manner, right? So I think some of the things that MedPAC is pushing underneath it that we need to pay attention to, and that we do need the bigger players. Like right now, the only one that I think is really stepping up into this is Humana as one of the bigger players. Most of the other hospice providers are all local hospice providers out there that are more picking, or health plan providers, or more local health plan providers. We need the Uniteds, we need some of the others in kind of coming into this game and actually help, I think, creating a better benefit and a better experience for their patients on their MA programs.
And I see a lot of head nodding
Yeah, I
coming
just
from
agree
you.
with everything that Mike and Steve just said. Yeah. I mean, this is, we have to build more we have to build more bridges between curative care. That's too jarring of a, people love hospice, totally agree, but it's too jarring of a transition. We have to have, that's what CMS is trying to do with VBID, and that's what they're trying to do with the value-based purchasing in hospice. But it is, I think, everything CMS does is fraught with sort of like, are we going to err too far on one side versus the other? And they tend to be very cautious. And then, we see this a little bit of a slower acceleration than we would like in some of these areas. But it's terrible for Medicare beneficiaries to be in a Medicare Advantage plan and then need hospice. It is it's horrible because now, but you're having your like co-pays are paid by Medicare Advantage, but I can't even explain it to our daughterhood community. It's just crazy. To me, that's the number one reason we should, if you're in a Medicare Advantage plan, you should be able to get your hospice benefit from your Medicare Advantage plan. So.
Great. I'm just keeping an eye on the time here. Let's transition to our last subject here, which is, let's try to dream big here together and think about, we just talked about COVID, we talked about PDGM and Medicare Advantage carve-in, and inherently the value of the home as a clinical setting has gone up in our belief as a result of COVID. There were a lot of tailwinds heading that way. COVID is reinforcing the home as the value of a home as a clinical setting, and the care and the coordination that can be delivered in and around the home is going to be continue to grow. So maybe let's each of you take a few minutes here to talk about, what type of services are being asked or demanded of you from either your patients, their caregivers, or the payers to do a lot of what Steve, you mentioned, which is we need to allow these individuals to live, reside, and ultimately pass with dignity in the home. And so what other services can we wrap around that individual and the home as the ultimate quarterback of care in the setting of care to enable them to do that? But there's also, we need to keep in mind who's going to pay for those services, right? And so there needs to be an alignment between the payers, the providers, the caregivers, and the ultimate patient to make a lot of these big picture ideas happen. But I'd love to dream big with you all a little bit and just talk about where we see this industry going over the next 3 to 5 years to deliver costs in the home at a high quality, better care at a lower cost.
And you're the expert.
Any volunteers that
You've
jump
done the
first?
study. You're like right in the middle of this. I think you should start.
I was just thinking that I wanted one of you to start this time, so where's everything going? Yeah, I mean, there's a lot of tension right now around the reimbursement system in all of this. We have to, there are a handful of organizations out there, like the one that Mike and Steve lead, that are pushing the envelope and figuring out ways to hack the system to do the things that we need this whole system to do, in 3 to 4, 5 to 10 years. And so the challenge is how do we get from a world in which the vast majority of organizations out there are just still kind of operating under old models and fee for service, to one in which, we've essentially scaled and normalized and institutionalized a totally different way of doing things for everybody. And that is, I think there's the challenge is that from a policy perspective, CMS has not been bold enough in terms of how much money it's willing to invest. And so I come from a budget perspective. I worked at the Office of Management and Budget, and we approach, and that was a long time ago, but even today, from a CMS actuary, an OMB standpoint, your inclination is to say, great, we're going to do ACOs, we're going to do direct contracting, we're going to do Medicare Advantage, whatever, as long as it's budget neutral to us, and the ACA put a lot of these sort of provisions in place for CMMI, like you can do all this cool stuff, but make sure it doesn't cost us any money. Which if you think about it is crazy, because what we've done is we've said to all of these private organizations, why don't you invest? And if you're lucky, we'll share some savings with you later. after you've made this big investment, you know, and after you've maybe proven to us that you can achieve these, you can move this Titanic, you know, in your market of this gigantic hospital and health system that's, you know, dependent, capital investments are dependent on fee for service. So we've gone through this 10-year experiment, and here we stand, having made some small, you know, we've got wonderful providers who are figuring out how to use all of this in order to move forward, but we still haven't scaled it. We still don't have, we haven't normalized it. And so I think, you know, I think we need flexibility, and we need risk-based contracting, and we need more shared savings, and we need the federal government to make more investments in essentially enticing providers along. You know, one last thing I'll just say about this is when I was in graduate school, my professor, Stuart Altman, who's a brilliant health policy guy, said, you know, the reason why hospital DRGs worked when we went from cost-based reimbursement to DRGs is because we overpaid the hospitals for a really long time. You know, we didn't start squeezing down until after they made the transition and all of the investments and they made some profit, and like, you know, we're not doing that. We're not sort of like overpaying the organizations that are really doing a good job of, you know, managing care transitions and care coordination. We make it hard for them. And all of those little point solutions that are doing this fabulous job, you know, have the potential to do a fabulous job, are basically begging and scraping the bottom of the barrel of health systems and payers to try to get funded. So, you know, I guess I would just say, I think the future is really bright. I think we have to move in that direction. I love Mike and Steve's optimism about where we're going. And I think that the most important thing that everybody can do at this point is start to have some real serious conversations with CMS about what it's going to take to get there. So that's my soapbox.
Thank you, Ann. Mike or Steve, any reactions?
Steve?
I would say, I'd say what you're going to see this industry significantly consolidate over the next 10 to 15 years. With that is going to be significant investment in the combination of at-home technologies and our ability to supply more on-demand services kind of into the home. And I think at the same time, you're going to see a greater integration into the broader clinical delivery system, where the home just becomes another treatment room.
Yeah, I totally agree. It's people want to stay at home. They want to stay at home now more than ever, and the outcomes are best from home. And on top of it, the costs are the lowest, right? So I, again, having done this for a long time, I drank the Kool-Aid early on. The home is the right place for patients, and it is the place that they can achieve the best results. You know, in hospice, patients live 20 to 30% longer once they choose the hospice benefit than any other alternative. And there's a reason for that, right? It's the socialization, it's the comfort, and the right care is given at the right time. And so I totally agree with Steve and Ann. We're at the very beginning of this. The model is going to change, I think, dramatically, and technology is going to have a huge part in that. I think the next Bill Gates is probably in healthcare focused around the home. I really do. It's the future of our country.
Well, with that, I think that's a great spot to conclude. A bright future ahead for all of us. And again, thank you on behalf of TripleTree for joining us for this discussion. I think we could have gone on for a long time across each of those subject areas, but a lot of change, a lot of transformation, and a lot of excitement ahead for healthcare in the home. So with that, Michael Carroll, I'll turn it back to you to conclude today's remarks. Thank you, everyone.
Thanks, everyone. That concludes today's Market Insights Live session. Our next session is 1 week from today, and it's focused on what's next in multi-site healthcare. For more information about all of our Market Insights Live sessions, you can visit triple-tree.com/Market Insights Live. And on behalf of everybody at TripleTree, I'd like to thank you for joining today, and a special thanks to our panelists for today's great conversation. Have a good day, and if you haven't already done so, please get out and vote. Bye-bye.